Now guys, coming to what? Coming to this topic of local anesthetics. Coming to this local anesthetics, we'll discuss each local anesthetic in detail. Starting with what? Starting with the first introduced local anesthetic. Nowadays it is the most abused one. What is that? Cocaine. Cocaine. Now regarding cocaine, 2 points you guys can easily tell. Without recollecting anything, you guys can, two points you can easily tell. First is what? Cocaine belongs to what? Amino ester or amino amide? Cocaine belongs to amino ester local anesthetic. Amino ester local anesthetic. Second point of cocaine is what, guys? It was the first introduced local anesthetic. It was the first introduced local anesthetic by Dr. Carl Koller. By Dr. Carl Koller from the leaves of erythroxylon cocoa. From the leaves of erythroxylon cocoa. Erythroxylon cocoa. It was the first introduced local anesthetic introduced by Dr. Carl Koller from the leaves of erythroxylon cocoa. Right? 2 points we have discussed. Next is what, guys? Next, it was the first used local anesthetic for what surgery? For eye surgery as well as spinal anesthesia. SX is surgery, AX is anesthesia. It was the first used local anesthetic for eye surgery as well as spinal anesthesia. Spinal anesthesia. Apart from that, remember guys, you should never give cocaine IV. Cocaine should never be given IV. Never be given IV as it causes potent vasoconstriction. As it causes potent vasoconstriction. Now this point of cocaine is very, very important. Cocaine should never be given IV. Why? Because it causes potent vasoconstriction. Now guys, why don't you give this cocaine IV? For this, why? Because it causes potent vasoconstriction. For this, I'll tell you a case. Basically, some 3 to 4 years back, I was posted in an ICU. I was doing a night duty. In the early morning, I got a call from the, basically when we are doing the ICU duty, whenever we get some time to sleep, like half an hour, if the patients are stable, we'll sleep. And that time, when I was doing the ICU duty, my other friend was there in the ICU. He was taking care of the cases. I was just sleeping for I took a nap for 1 hour, and the doctor from the emergency, he called me and told that there is a young guy who's being diagnosed with stroke. Young 19-year-old guy who's being diagnosed with stroke. He's being admitted under the care of some doctor. You just take care, from there. He told me to take care of the patient. So anyways, the patient was shifted to ICU. I went to the patient. I asked him, basically, before going to the patient, I was having a picture in my mind that 19-year-old guy developing stroke, it's very rare, guys. I was having a picture that he might be obese or something. When I went to the patient, I was shocked to see him. He was a well-built guy. He was never obese. He was a fit guy, fitter than me, fitter than anyone. He was very fit. So I got shocked. Why he got stroke? It's very rare, no, to see strokes and all. So I was thinking that he might be having a family history of hypercholesterolemia. I checked his cholesterol levels. It was totally fine. I asked him, are you having any history of hypertension? He was telling me, no doctor, what hypertension? I don't know what is hypertension. I am not having any hypertension history and all. I was confused what happened to him and all. Basically, I was taking history in front of his parents. Once his parents went, he called me. He told what? Doctor, I'm not having any history, nothing, but I am cocaine drug abuser. I use cocaine as an IV drug. When he told me this, everything, the picture of him got very crystal clear. I totally understood that this guy is having stroke. Why? Because he had taken cocaine. Cocaine causes potent vasoconstriction. Due to vasoconstriction, his BP had shot up. Acutely, the BP shot up. He was not a hypertensive patient. Acutely, his BP shot up. But due to his regular doses of cocaine, this BP was shooting up. And what happened? If your BP shoots up, the pressure inside the artery increases and all. At one point, the pressure of the artery, if it increases and the artery becomes weak, the artery will rupture, leading to stroke. Yes or no? So this patient also had that stroke. So remember guys, anyways, cocaine should never be given IV. Why? Because cocaine is a potent vasoconstrictor. It should be constrictor. It should be avoided IV. It should never be given IV. That was regarding what? That was regarding cocaine. That was regarding cocaine. Coming to the next local anesthetic that we need to discuss, which is called as chloroprocaine. Which is called as what, guys? Chloroprocaine, or it is also called as chloroprocaine. Chloroprocaine. So remember guys, whenever we are discussing this chloroprocaine, we'll discuss two things over here. One, we'll discuss chloroprocaine. We'll discuss two local anesthetics together. Chloroprocaine and procaine. We'll discuss these two together. Chloroprocaine and procaine. Why are we discussing together? Are both the same? No. Why? Why? Because these are the short-acting local anesthetic. Chloroprocaine and procaine, these are the short-acting local anesthetic. Short-acting local anesthetic. Among these two, the shortest among these two is chloroprocaine. The shortest acting local anesthetic is chloroprocaine. So chloroprocaine and procaine are the short acting local anesthetic, but which is the shortest among these two? The shortest among these two is chloroprocaine. Chloroprocaine. Anyways guys, the next thing that I am going to ask you is, in which category they belong? Amino ester or amino amide? Come on, think. They belong to amino ester or amino amide? These two drugs, they belong to amino ester category. They are amino ester. Why sir? Why are they amino ester? Why? Because sir, they are having how many eyes? One eye. All amino esters have one eye. One more extra point of these drugs that we need to remember is, procaine is the safest local anesthetic. Procaine is the safest local anesthetic in patient with malignant hyperthermia. In patient with malignant hyperthermia. Very, very important. Malignant hyperthermia. What is meant by malignant hyperthermia, guys? First, we need to understand what is this malignant hyperthermia. Malignant hyperthermia meaning what? Patient having abnormally high temperature. Patient having an abnormally high temperature with sustained muscle contraction. I am not talking about rigors and chills. Malignant hyperthermia means abnormally high temperature with sustained muscle contraction is called as malignant hyperthermia. In malignant hyperthermia, the safest local anesthetic is procaine. The safest is procaine, right? So that was regarding procaine and chloroprocaine. Coming to the next local anesthetic, which is called as lignocaine. Which is called as what, guys? Lignocaine. Come on. Lignocaine, I have already told you what's the other name for lignocaine. It is lidocaine or xylocaine, sir. They belong to what category? We have to remember first. Lignocaine. Lignocaine. They kya? Lignocaine. Lignocaine belongs to amino ester or amino amide? Ester or amide? It belongs to amino amide. Why it is an amino amide? Why? Because sir, amino-amide drugs will have two eyes, lignocaine is having two eyes. So lignocaine belongs to amino-amide category. Next, one more point that comes to your mind regarding lignocaine. Come on guys, it is the most commonly used local anesthetic. LA is local anesthetic. Okay? It is the most commonly used local anesthetic worldwide, right? Next, it is the second most commonly used local anesthetic in spinal anesthesia. What anesthesia? Spinal anesthesia. Then which is the most commonly used in spinal? The most commonly used local anesthetic in spinal is Bupivacaine. And you guys know what's the reason why Bupivacaine is most commonly used in spinal. Why? Why? Because Bupivacaine is a longer acting when compared to Lignocaine. Right? Next. Lignocaine is the most common local anesthetic to cause malignant hyperthermia. Which was the safest in malignant hyperthermia? Guys? Procaine. Lignocaine is the local anesthetic that can cause malignant hyperthermia. There are many most commons in lignocaine. That's why it is commonly used worldwide. Right? Next, lignocaine is the most commonly used local anesthetic or most common local anesthetic to be used in IVRA. Come on guys, what is IVRA? What is meant by IVRA? All the points of lignocaine are important, guys. All the points of lignocaine are important. What is meant by IVRA? IVRA full form is intravenous regional anesthesia. What is this intravenous regional anesthesia? Again, with the help of case, we will go towards it, okay? We can't proceed further without knowing what is IVRA. Even though we can proceed, but we have to remember, guys, what is IVRA and all. So look over here, guys. Imagine a 95-year-old patient. 95-year-old patient goes towards the surgeon. He is having Colles fracture. The patient is having Colles fracture. He goes towards the surgeon and is telling the doctor, repair my Colles fracture. It is very painful. The surgeon will tell that, okay, don't worry, I'll repair your fracture. I will go for any fixation. Some fixation he'll tell, okay? The 95-year-old guy is very much like concerned about the pain. He is asking, will I have pain during surgery? So what will the surgeon do? The surgeon will tell you won't have pain, but first go towards the anesthetist, have your PAC done, then we can proceed further. So imagine that 95-year-old guy comes to me, I am the anesthetist, he comes to me for the PAC. In the PAC, you guys know what are the 4 essential and the most important things. Airway, hemoglobin, fasting, history of comorbidities. Right? Which is the most important? Airway. So anyways, guys, the patient came to me for a PAC. So what should I do, guys? What should I do? I have done the PAC. Now in the PAC, the last thing is history, no? I am taking the history of the patient. This patient is telling me what? Doctor, I have been a smoker from the age of 15. Now my age is 95. I did not stop smoking. I am basically smoking cigarettes from the last 80 years. And for that smoking, due to that smoking, I got a disease called as COPD. I got a disease which is called as what, guys? COPD, he's telling. Okay. So now you are still taking the history. You are also asking, apart from smoking, is there any other problem with you? He's telling the doctor, 2 years back, I was being diagnosed with heart disease. And now my ejection fraction of the heart is 25%. Normal ejection fraction should be more than 60%, but his ejection fraction is 25%. So guys, his heart is in a bad state. His lungs are in a bad state. He's asking me doctor, which anesthesia will you give? He's also giving me some options, guys. He's telling me, doctor, can you do it under local anesthesia? I'm saying what? No, it can't be done under local. Local usually works on the skin and mucous membrane, not on the bones. Okay. He's asking me, doctor, will you give me spinal anesthesia? I'm telling, sir, spinal is not at all an option. Spinal anesthesia is given for the surgeries done below the level of umbilicus, that too within how many hours? 2 to 3 hours. Epidural is also not given. Spinal is not given, epidural is not given, local is not given. Okay? He's asking me, sir, please make me fully unconscious. Tell him, sir, you are not fit to undergo general anesthesia. Your heart is in a bad state, your lungs are in a bad state. If I give you general anesthesia, then you have to first give me a consent of on-table death. Now he'll be confused what to do. You can't give him local, you can't give him spinal, you can't give him epidural. You are not going for a risky procedure called as general anesthesia. What are you left out with, guys? Nerve block. Nerve block is a very good option in such patients. Why? Because you are just blocking the plexus of nerve. Now, as he's having Colles fracture, you can go for brachial plexus block. But this nerve blocks comes with very much complications. Complications are associated with nerve block. Sometimes, imagine this is the needle to identify the nerve, to give a nerve block. Sometimes, in order to find the nerve, sometimes while finding the brachial plexus, what can happen? Your needle can touch the pleura, damage the pleura, leading to pneumothorax. Already the patient's lungs were in a bad state. Now he developed pneumothorax, right? What will happen? Directly he'll go up. Nerve blocks, if you are going for ultrasound guided nerve blocks, you can go for it. But imagine you don't know how to give nerve blocks, or if you don't, or if you know but you don't have the facility to give nerve block, yani you're not having ultrasound machine available, then what is the option for this patient? You can't give local, you can't give spinal, you can't give epidural, you can't give nerve general, you can't give nerve block. What will you tell the patient? 95 years is a very good age, sir. You have already lived 95. More how many years will you live? Will you tell the patient this? No. You won't tell the patient. You won't go for negative counseling. What you will tell, if I was there in that scenario, what I'll do? I'll call the surgeon and tell that I am taking the patient in the operation theatre. You also come. After taking the patient into the operation theatre, I will raise the patient hand for 8 to 10 minutes. How many minutes? 8 to 10 minutes. As I am raising the patient's hands for 8 to 10 minutes. First of all, why did I raise the patient's hands for 8 to 10 minutes? Why? Because all blood from the upper part, it should come down and settle at the bottom. Basically, I am emptying the hand. I am emptying the hand, right? After emptying the hand, I will, by keeping the hand in this position, I will apply a tourniquet. I will apply a tourniquet. What is meant by tourniquet, guys? What is meant by tourniquet? Tourniquet is any instrument or any device that is used to apply pressure in order to stop the blood supply for some time. That is called as tourniquet. A BP cuff is a tourniquet. A rope, you can use a rope as a tourniquet. Rope. You can use a glove. You can use anything that is used to apply pressure as tourniquet, guys. So remember, guys, the first step is raise the hand for 8 to 10 minutes. Second step is what? You apply the tourniquet or a BP cuff. And third step is what? Now you have inflated this tourniquet. Tourniquet is tightly inflated. Now the blood from this side won't go to this side. Any blood or drug which is given at this side, it won't go for systemic circulation. So after applying tourniquet, you put an IV cannula, you take this drug called as Lignocaine and inject this Lignocaine through the IV route. As you are injecting this Lignocaine through the IV route, your Lignocaine will go to this area. Will it go up? It won't go up. Why? Because the tourniquet is not allowing it to go up. Your Lignocaine will go to this area and it will cause what? It will just block the sensations of this area. Right? Is it going up? It's not going up. So basically, you are receiving a regional anesthesia by giving the drug through the IV route. That anesthesia is called as IVRA. Now, this technique is called as what, guys? IVRA. IVRA. So remember, guys, you are achieving a regional anesthesia by giving IV drug. It is called as intravenous regional anesthesia. And what is the drug of choice in IVRA? What is the local anesthetic of choice in IVRA? It is Lignocaine. It is what, guys? Lignocaine. Now you got this technique. What is IVRA? Right. Now, next is the dose. Dose of Lignocaine. What is the dose of Lignocaine that you give to the patient? When you are giving plain Lignocaine, the dose should be 4.5 mg per kg body weight. When you are using Lignocaine with adrenaline, the dose should be 7 mg per kg body weight. When you are giving plain Lignocaine, the dose is 4.5 mg per kg body weight. When you are using Lignocaine with adrenaline, the dose is 7 mg per kg body weight. When you give plain Lignocaine in this dose, what will be the duration of it? It will act for 45 minutes to 1 hour. Why are you adding adrenaline to Lignocaine? In order to increase the duration. So once you add adrenaline to Lignocaine, then the duration will be how much, guys? Then it will act for up to 2 hours. It will act up to 2 hours. So dose of plain Lignocaine is how much? 45 minutes to 1 hour. Whereas Lignocaine with adrenaline, what's the dose? Up till 2 hours. The dose is very, very important. In anesthesia, most of the things are not that, but this dose is very, very important, guys. The dosages are not that important in anesthesia, but the dose of Lignocaine is very, very important. Plain Lignocaine 4.5 mg per kg body weight. Lignocaine with adrenaline, what's the dose, guys? Lignocaine with adrenaline, the dose is 7 mg per kg body weight. Okay. Why are you adding adrenaline to Lignocaine? You add adrenaline to Lignocaine, we have already discussed. Why do you add adrenaline to Lignocaine? In order to increase the... Why do you add adrenaline to Lignocaine? In order to increase the duration, right? The duration. So, but I told you, adrenaline with Lignocaine, it should be avoided in what patients? Adrenaline with Lignocaine should be avoided in what patients, guys? Hypertensive patient, ischemic heart disease patient, and in the places where you have end arteries. In the places where you have end arteries. Where you have end arteries? Fingertips, toe tips, penile tip, pinna, you have end arteries. So adrenaline with Lignocaine would be avoided over there. So this is regarding what, guys? This is regarding the Lignocaine. Now, we also need to remember the concentration of Lignocaine. Concentration of Lignocaine. Concentration. For concentration to remember, first of all, we need to understand what is the difference between dose and concentration. Dose means what, guys? You calculate it according to the body weight. Concentration means what? How much amount of Lignocaine is present in the water to make it as a solution. It could be 2%, it could be 4%, it could be 10%, it could be 5%. Usually 2, 4 and 5% of Lignocaine will be there. Okay? Concentrations of, is right there, concentration of Lignocaine used in various anesthesia techniques. Concentration of Lignocaine used in various anesthesia techniques. Right? For that there is a mnemonic. Guys, when you go into the hospital, you will see a Lignocaine vial, no? Just look at the vial, there will be written 2%. There will be written 4%. What is a 2% or 4% means? Basically, concentration means what? How much amount of Lignocaine is added to a water to make it as a solution. That is concentration. There have been questions asking you about what is the concentration of Lignocaine used in IVRA. Okay? For that, there is a mnemonic, guys. For techniques of anesthesia, concentration of Lignocaine that is used is, there is a mnemonic to remember. The mnemonic is INETS. I stands for IVRA. The concentration of Lignocaine used in IVRA is how much, guys? 0.5%. 5%. N stands for nerve block. E stands for epidural. In nerve blocks and epidural, the concentration of lignocaine that is used is 1 to 2%. 1 to 2%. T stands for topical. The concentration is 2 to 4%. S stands for spinal. The concentration of lignocaine used in spinal anesthesia is 5%. So remember, concentration is what, guys? How much amount of lignocaine is added to a water to make it as a solution. That is called as concentration. That is called as what, guys? Concentration. In IVRA, what's the concentration that we use? 0.5%. Nerve blocks and epidural, what's the concentration that we use? 1 to 2%. T is topical, the concentration that we use 2 to 4%. S is spinal, the concentration of lignocaine that we use is 5%. 5%. So that was regarding the concentration of lignocaine, right? The calculation of concentration is not important, guys, but what we need to know is, guys, once again, what is the dose of plain lignocaine? What is the dose of plain lignocaine? Plain lignocaine is how much? 4.5 mg per kg body weight. And ligno with adrenaline, it is 7 mg per kg body weight. Now, guys, again, I'll give you a case so that you can understand about the toxic effects of lignocaine and how will you manage that toxicity and all, okay? So, guys, imagine you have finished your exams and all, then now you're preparing for your NEET-PG, and as you're preparing for your NEET-PG, you have prepared, you have given your NEET-PG, you got a rank and you took a seat in anesthesia. You took a PG seat in anesthesia, okay? So imagine, guys, you have taken this PG seat in anesthesia, and imagine you have joined in a hospital where I am working as a second year PG. Okay? I have finished my anesthesia years back, guys. Just for imagination, just look over here. Imagine I am your second year PG, you are my junior. Okay? So the rule is basically whenever any new PG joins our department, the first thing that we do is what? Now don't tell me ragging and all. Ragging and all is not done, guys. We are not kids. Okay? We are talking about the post-graduation. Why? Because in my offline classes, most of the students, they tell, what do you do? They will tell ragging. It's not that. So first thing, when our PG joins our department, I'll take my PG to the operation theaters. Like I'll show him here local anesthesia is given, here spinal is given, in this operation theater general is given, in this operation theater neurosurgeries are done, in this operation theater orthosurgeries are done. I'll give the introduction. Basically the first month we are just introducing them to the things. We are not giving any procedures in the first month. In the second month you will be getting the procedures. You will be getting to perform the procedure. So imagine you have joined the department, right? And after joining the department, I have given you the introduction to the anesthesia techniques. I have given you the introduction of local anesthetics. I have basically taught you much things on the first day. Imagine after 7 days, imagine on January 1st you joined the department. On January 7th, on January 1st you joined, and on January 7th, we all went to the hospital. You also came to the hospital, I also came to the hospital. But my colleagues, they did not come. My other anesthesia colleagues, they were absent. Assistant professors, all were absent. Only I was there and you were there. And on that day, we had a list of cases to be done. So I requested you that, guys, you just take care of the cases which are done under local anesthesia. I will take care of some cases which are done under spinal and general anesthesia. Because I am the only one who is a bit senior to you, right? So I know the techniques, how they are performed. Okay? I have given you an introduction of local anesthesia and all you have observed. But as there were no other experienced people, what I did, gave you the less risky one. I gave you the local anesthesia cases. So you were also very happy that the things that we have to perform in the second month, we are getting it performed on the 7th day. So you guys will be very happy that we are getting the procedures. Now what will happen? Look over here. I'll tell you, you guys take care of local. I am taking care of general and spinal. I'll be in my operation theatre, you guys are in your operation theatre. You are taking the patient into the operation theatre, right? And before taking the patient's relatives were asking you, sir, how many hours surgery is it? Is it a major or a minor thing? The anesthesia will be major or minor. You are telling what? You are basically very much happy, and now you are excited also. In that excitement, you told the attenders or the relatives what? It is just a case which is done under local anesthesia, which will be done within how many minutes? Which will be done within like half an hour to 45 minutes. It will be done. Your patient will be fully conscious. You don't have to worry and all. So they are also happy. Patient is happy. You are very much excited and happy that you are performing the first local anesthesia. You take the patient to the operation theatre, right? In that excitement, you have done a small mistake. While loading the drug, you have done a small mistake. Okay? Basically, you have joined the department as a new trainee. You have been stuffed with much knowledge. But here, while loading the dose, you fumbled upon what is the exact dose. You thought plain lignocaine is given in a dose of 8 mg per kg body weight. Is it so, guys? Is the plain lignocaine given in 8 mg per kg? No. Plain should be given in 4.5. But you thought that and you loaded that plain lignocaine in a high dose or a toxic dose you have loaded of lignocaine. But you are not aware of it. Now you are happily giving this lignocaine to the patient. And before starting lignocaine, you tell your friend that please record the incidents. Please record these things. Why? Because nowadays we are having this habit, guys. Wherever you do any new thing, what we do? We upload those images on Snapchat, Instagram. Okay? You are basically telling your friend that take a live video, post it on Instagram saying that hashtag on Twitter also, hashtag my first anesthesia, my first local anesthesia. You are basically very happy. Your friend is posting the video online, is live, right? So he's taking the video. You are giving this lignocaine to the patient. You're not aware that you are giving a toxic dose. As you are giving this lignocaine to the patient, slowly patient will tell, doctor, I am having some numbness or tingling sensation near my lips. Numbness or tingling sensation near my lips. That is called as perioral numbness. He complained of that. What you will tell to the patient? You will tell what? Hey, bhai, don't talk anything. This perioral numbness or this tingling sensation is totally normal. Enjoy your local anesthesia. Patient will be okay. Patient is not having any knowledge. But at the same time, you are also very new. So you are not having knowledge, you are confusing the patient. So you told him what? This is totally normal. After lignocaine, this will happen. Okay? You are thinking this is normal. Now slowly, you're still not stopping. You're still continuing lignocaine. Now slowly, the patient will have tremors. As the patient is having tremors, now you will be confused what is happening to the patient. Your friend who is recording the video, he's also half knowledge. He's telling what? Arey bhai, your lignocaine is working wonders. The patient is now having tremors. So you will think what? Perioral numbness was also normal. Tremors are also normal. You become more confident. Arey, tremors, perioral numbness, then tremors, yani ke my lignocaine is now working. You are thinking your lignocaine works in this fashion. Right? But you are not stopping. You are continuing. Now the patient lands up into seizures. Once the patient lands up into seizures, you tell your friend to stop the video. And then now you are panicked. You come to me running and saying what? Sir, in our operation theatre, the patient who we took for local anesthesia, he is having seizures. I come to your operation theatre, I see what? The patient is having seizures. What should I do? Should I scold you? Or should we talk about seizures? Or should we manage seizures? Very good. We should manage seizures. How will you manage seizures? By giving benzodiazepine. I'll give a benzodiazepine, seizure episode is gone. Now I will talk with you. Why? Why did he have seizures? Are you having idea of it? You were basically not aware that you have given a toxic dose. You don't have any idea why the patient had seizures. I also don't have any idea. I just came and I saw the patient is having seizures. I'm basically asking you the other possible causes of seizures. I'm asking you, did the patient had the history of seizures? You're telling, no sir, patient did not have the history of seizures. We have done the PSC. I'm basically asking you about the other causes of seizures. Hypoglycemic induced seizures. Any seizures could happen. Patient's blood sugar level is also normal. We are having this discussion why the patient is having seizures. While we are having this discussion, what happens is the patient saturation, which was 99, it becomes 90. From 90 it becomes 80. From 80 it becomes 70. What should I do, guys? The patient is desaturating. Leave the cause of seizures at that time, and what we need to do? What we need to do? If he is having fall in saturation, give him oxygen. How will you give him oxygen? Two options I will give. Will you go for a mask oxygenation or will you go for endotracheal intubation? The best way to give oxygen to the patient when you are 100% sure that you are ventilating the lungs only is what? Endotracheal intubation. You go for endotracheal intubation. You put the endotracheal tube, and now after putting the tube, discuss the causes. But imagine I am also half knowledge. I am seeing the patient is having fall in saturation. What I am doing is I am just having conversation with you. Leave the saturation. We will have conversation. Why the patient land up into seizures? What will happen to the patient? Patient will desaturate. Patient saturation, which was 70, it becomes 50, 40, 20, 10, 0. Patient develops respiratory arrest, ultimately leading to what arrest? Cardiac arrest. Patient dies. Right? Remember, guys, remember, you can prevent the cardiac arrest. How? If you manage the respiratory, if the patient is having respiratory discomfort, you go for the main management of lignocaine toxicity. What is the main management? Intubate and ventilate the patient till he recovers. Intubate. So imagine I have intubated the patient. Now after intubation, now you are getting more panic. You come nearby me and you ask, doctor, will the patient survive or not? What should be my answer? Will he survive? First I'll ask you, why are you asking this? You will tell what? No doctor, before taking the patient into the operation theatre, in our excitement to give first local anesthesia, we told all the attenders, all the relatives of the patient that patient will be fully conscious, don't worry about the patient and all. And now the patient is on ventilator. Right? So now you are very much panicked. So basically, before answering you whether the patient will survive or not, I'll ask you what? Now I'll get this picture clear that, remember, now I'll try to compile all the symptoms of toxic dose of lignocaine. I'll ask you, did the patient have perioral numbness? You will tell, yes sir, perioral numbness was seen. Then I'll also ask you, did the patient have tremors? You will tell, yes sir, tremors were also seen. Then only we proceeded. Then I'll tell you, bhai sahab, perioral numbness and tremors are the signs of lignocaine toxicity. That means you have given lignocaine in what dose? Toxic dose. You have given lignocaine in what dose, guys? Toxic dose. The first sign of lignocaine toxicity is what? Perioral numbness. Followed by what? Tremors. Followed by what? Respiratory discomfort. Followed by seizures. Remember now our case. First patient had perioral numbness, then tremors, then seizures. Then what will happen? The patient will have respiratory discomfort. If you don't manage respiratory discomfort, patient will develop respiratory arrest, ultimately leading to what arrest? Cardiac arrest. So these are all signs of lignocaine toxicity. As lignocaine toxicity is first producing perioral numbness, followed by tremors, followed by seizures. Remember, these are the signs of what toxicity? CNS toxicity. Due to this, lignocaine is always called as a central nervous system toxic drug. CNS toxic drugs. Lignocaine is called as a CNS toxic drug. Right? CNS toxic drug. If you don't manage CNS toxicity, then what will happen? Then cardiotoxicity can happen with lignocaine. Right? So once again, guys, we are talking about what? Lignocaine toxicity. Lignocaine produces Lignocaine produces CNS toxicity. Lignocaine produces what toxicity, guys? Central nervous system toxicity. CNS toxicity, right? So if you give lignocaine in a toxic dose, the first sign of lignocaine toxicity is what? What's the first sign of lignocaine toxicity? The first sign of, this is an important MCQ, guys. First sign of lignocaine toxicity. Remember the case, you will remember the sign also. The first sign of lignocaine toxicity is perioral numbness. Perioral numbness, right? Very, very important. Followed by tremors, followed by seizures, followed by respiratory discomfort. If you don't manage that respiratory discomfort, patient will develop what arrest? Respiratory arrest, ultimately leading to what arrest? Cardiac arrest. Ultimately leading to what arrest, guys? Cardiac arrest. Cardiac arrest. So perioral numbness followed by tremors followed by seizures, respiratory discomfort leading to respiratory arrest, ultimately leading to what arrest, guys? Cardiac arrest. So these are the signs of lignocaine toxicity. How will you manage lignocaine toxicity? Very simple, guys. Lignocaine toxicity is easy to manage. Coming to your question was, will the patient survive or not? What's the answer? 100% he will survive. Lignocaine toxicity can be easily managed. What is the main management of lignocaine toxicity? The main management of lignocaine toxicity is, come on guys, the main management of lignocaine toxicity is intubate and ventilate the patient till he recovers. Intubate and ventilate the patient till he recovers. Apart from that, what else we need to remember? Apart from ventilating the patient till he recovers, what else we need to remember? We need to remember that we can go for anti-epileptic medications, anti-epileptic medicines if patient has seizures. If patient has seizures, you go for anti-epileptic medication. That's regarding what toxicity, guys? Lignocaine toxicity management. Lignocaine toxicity management. Coming to this drug, coming to the next local anesthetic, which is called as Bupivacaine. Come on guys, regarding Bupivacaine, 2 points you guys can tell me. First tell me, Bupivacaine belongs to what? It belongs to amino ester or amino amide. Till this time you should be perfect. What is an amino ester and what is an amino amide? Amino ester, 1I. Amino amide, 2I. So amino ester, remember Bupivacaine belongs to what? Bupivacaine belongs to amino amide category. Why it belongs to amino amide? Why? Because it's having 2 I's. Next point of Bupivacaine that we need to remember is Bupivacaine is the most commonly used local anesthetic in what anesthesia? In spinal anesthesia. Bupivacaine is the most commonly used local anesthetic in what anesthesia? In spinal anesthesia. Spinal anesthesia. Dose onset is not important. The duration of Bupivacaine is important. Whenever you give this Bupivacaine to the patient, it acts for how many minutes or how many hours? Lignocaine was acting for 45 minutes to 1 hour. Bupivacaine plain also, if you give, it will act for 2 to 3 hours. 2 to 3 hours. That is the duration of bupivacaine. But does that mean that bupivacaine is the longest among all? No. Bupivacaine is longer when compared to what? When compared to lignocaine. Right? Is bupivacaine the longest acting local anesthetic? Bupivacaine is not the longest. Which is the longest acting local anesthetic? Just write there, guys. Heading as longest to shortest acting local anesthetic. Longest to shortest acting local anesthetic. The longest acting local anesthetic is Dibucaine. Second longest acting is Tetracaine. Shorter than Tetracaine is Bupivacaine. Shorter than Bupivacaine is Lignocaine. Shorter than Lignocaine is Procaine, and the shortest among all the local anesthetic we have already discussed. The shortest among all the local anesthetic is what, guys? Chloroprocaine. Okay. So which is the longest, guys? Dibucaine. Second, tetra. When you are having Dibucaine and Tetracaine available as an option, why do you choose Bupivacaine? Remember, even though Dibucaine and Tetracaine are the longest, these are the most toxic local anesthetic. These are the most toxic local anesthetic. Hence, most commonly we choose what? We choose Bupivacaine. There is a mnemonic to remember this, guys. Longest to shortest acting local anesthetic mnemonic is Delhi to Bombay loves PC. Delhi to Bombay loves PC. Who's PC? It's not Priyanka Chopra, not Pariniti Chopra, it is Procaine and Chloroprocaine. So remember, Delhi to Bombay loves PC. In that, D stands for Dibucaine, T Tetracaine, B Bupivacaine, L Lignocaine, P is Procaine, and the shortest is what? Chloroprocaine. So we are discussing about Bupivacaine. It is the most commonly used local anesthetic in spinal anesthesia. Why? Why? Because it is having a longer duration when compared to what? When compared to Lignocaine. Right? So, which is the longest? Dibucaine. Second, Tetracaine. When they are the longest, why they are not used commonly? Why? Because the reason is what? These are the longest as well as the most toxic local anesthetic. These are the longest as well as the most toxic local anesthetic. Does it mean that Bupivacaine is free from toxicity? No. Bupivacaine is also not free from toxicity. Bupivacaine also causes cardiotoxicity. Bupivacaine also causes what toxicity? Cardiotoxicity. Bupivacaine is the most cardiotoxic local anesthetic. Bupivacaine is the most cardiotoxic local anesthetic. Now guys, stop over here. When I am telling Bupivacaine is the most cardiotoxic local anesthetic, why are we using that Bupivacaine in spinal anesthesia? Why? When it's the most cardiotoxic, avoid it, no? Dibucaine and Tetracaine you were avoiding. Why? Because it causes multi-system toxicity. Bupivacaine also avoid. Remember guys, which toxicity is easy to manage? CNS, not CVS. Cardiotoxicity is very difficult to manage. When cardiotoxicity is difficult to manage, then avoid this cardiotoxic Bupivacaine, no? Why it is commonly used in spinal? Because the reason is what? Bupivacaine, if you give in the CSF, no chances of cardiotoxicity. In spinal, you are giving the drug in the CSF. But if Bupivacaine is given inside the blood vessel by mistakenly, then what will happen? Cardiotoxicity will happen. Right? There was one of my junior guys. He was posted in the, basically it was a first year PG. It was his second or third month, it's not second month only, second month of the anesthesia residency. He got a call from the hospital saying that there is a patient posted for LSCS. Please come and give her spinal anesthesia. So he was a first year PG, and a third year PG was also on duty with an assistant professor. So first year, what he did, he took the first year PG took the third year PG with him, and he told that, sir, I will give spinal anesthesia, you just observe. As he was giving his second or third spinal, he was very new to spinal. He told the third year PG that please sit there and observe, I will give anesthesia. This new first year PG, he was introducing the needle into what space? In the spinal anesthesia, we usually go for the L3 to L5 space. He introduced the needle and he took the needle till the subarachnoid space. Once he was in the subarachnoid space, he waited for the drops of CSF. Normally, we wait for the drops of CSF. How will be the drops? Once you are in the subarachnoid space, you wait for the drops of CSF. What is the color of CSF? The color of CSF will be colorless or straw color. He waited for the drops of CSF. Okay? But as he was new, he was not having any idea how the CSF looks like and all. He was having some idea. What he saw at that time, the CSF was coming, but the color of the CSF was a bit reddish tinge. There was a reddish tinge in the CSF. He thought that is the normal CSF color. He took this Bupivacaine, gave it into the CSF, thinking that it is going into the CSF only. But what happened? Why there was a reddish tinge? Why? Because some blood vessel. The blood was coming from the blood vessel over there. So remember, guys, what will happen? If you see blood in the CSF, that means some blood vessel is being damaged, and that blood vessel, if it is blood is coming continuously, that means now if you give Bupivacaine, where it is going? Inside the blood vessel. So by mistakenly, he gave this drug Bupivacaine inside the blood vessel. He was not knowing, he was still not aware of it. He gave the Bupivacaine, make the patient lie down. As he made the patient lie down, what he did, what he saw is something weird on the monitor. Normally, guys, after giving spinal anesthesia, the patient's BP will fall down. If the BP is 120/70, it becomes 80/40. That is the normal thing to be seen after spinal. But what he saw after giving spinal, the patient's BP became 200/100. Is it normal or abnormal? Very much abnormal. Asked his third year PG, sir, the BP of the patient is in a very high state. The third year PG also told, did you give spinal? He asked him, did you give spinal? He told, yes, sir, I gave spinal to the patient. He was confused. After giving spinal, the BP should fall. The third year PG asked the patient, the senior PG asked the patient, like the patient was anxious also. So he thought that the patient's BP is raised due to anxiety. So the senior PG, what he told, okay, the patient's BP is on a higher side, we will just lower down the BP, right? But by the time they were noticing BP, they saw the change in the heart rate. The heart rate begins to fluctuate and they were seeing some arrhythmias developing on the ECG. Now the senior PG told, immediately give the patient anti-arrhythmic drug. So this junior PG was loading the anti-arrhythmic drug. By the time he was loading the anti-arrhythmic drug, the patient's heart rate becomes zero. Patient heart rate becomes zero. Patient developed cardiac arrest. Now what would have happened, guys? Remember, Bupivacaine, unlike Lignocaine, Lignocaine was giving you much time to reach the cardiotoxic effects and all. But Bupivacaine does no nonsense like Lignocaine. Directly it causes cardiotoxicity, and within no time the patient will develop what arrest? Cardiac arrest. Patient will develop cardiac arrest. But all these toxicities will happen with Bupivacaine if you give Bupivacaine intravascular. If you give in the CSF, no problem. But if it is given intravascular, you will see what? Cardiotoxic effects of Bupivacaine. How will you manage Bupivacaine-induced toxicity, guys? Lignocaine-induced toxicity, we know. Bupivacaine-induced toxicity, how will you manage? Bupivacaine-induced toxicity, remember, if the patient is developing arrhythmias, give anti-arrhythmic drugs, amiodarone, procainamide. Okay? If the patient develops cardiac arrest, give CPR and adrenaline. But that's not the main management. The main management of Lignocaine toxicity is you can give an antidote against, the main management of Bupivacaine toxicity is you can give an antidote against Bupivacaine. What is that antidote called as? 20% intralipid solution. Once again, percentage is very important. What's the percentage? 20% intralipid solution. So remember guys, bupivacaine is the most cardiotoxic local anesthetic. It is the most cardiotoxic local anesthetic. It causes cardiotoxicity by acting on what channels? By acting on sodium channels, right? So it should never be given intravascular. IV is, it should never be given intravascular. If you give intravascular bupivacaine, then you should be ready with the drugs to manage the complications of it. What are the drugs, guys? Bretylium, amiodarone, procainamide, all are antiarrhythmic drugs. The drug of choice for bupivacaine induced cardiotoxicity is intralipid solution. 20% intralipid solution. 20% intralipid solution is the main management of bupivacaine induced cardiotoxicity. Apart from that, we can give what? We can give the supporting management, which includes bretylium, amiodarone, procainamide. These are antiarrhythmic drugs. But the drug of choice remains what? Intralipid, 20% intralipid solution. Right. Next, coming to the next local anesthetic, which is called as Dibucaine. Come on guys, Dibucaine, you guys can tell me a few points of Dibucaine. Yes or no? Dibucaine. I told you what? Dibucaine is the longest acting local anesthetic, but it is not used. Why? Because it is the most toxic local anesthetic also. It is the most toxic local anesthetic, Dibucaine. Right? Dibucaine is only used for a test which is called as Dibucaine number test. Dibucaine is only used for Dibucaine number test. And what does this Dibucaine number test depicts? This Dibucaine number test detects the atypical pseudocholinesterase, or pseudocholinesterase deficiency. Pseudocholinesterase deficiency. Dibucaine is not used for any local anesthesia or local anesthetic purpose. Dibucaine is only used for Dibucaine number test that detects the atypical pseudocholinesterase or pseudocholinesterase deficiency. Okay, so that were a few local anesthetics, guys. Next is surface anesthesia. What is meant by surface anesthesia? Surface anesthesia means when a local anesthetic is applied on the skin or the mucous membrane, it is called as surface anesthetics or surface anesthesia, right? So guys, I'll give you examples. There is a thing called as Ryle's tube insertion or Foley's catheterization. You know what is Ryle's tube? Ryle's tube is a tube that you put into the patient's nose that goes into the esophagus, and then the patient is given the feeding. Imagine a patient is there who's being diagnosed with stroke. Stroke patient will have paralysis of one side of the body. He can't ingest the food. He can't urinate properly. For those patients who is being diagnosed with acute stroke, what we do is we put a Ryle's tube and Foley's catheter so that they don't have any problem. So this patient who is being diagnosed with stroke, I am advising you to put a Ryle's tube. While putting a Ryle's tube, you don't put the Ryle's tube directly. What we do, we apply a Lignocaine gel into the hand, then we pre-lubricate the Ryle's tube, and then we insert the Ryle's tube through the nose into the patient's esophagus, right? So that is basically surface anesthesia. We are basically anesthetizing the nose or the nasal mucosa so that the patient won't have the pain during insertion. So remember guys, surface anesthesia means when local anesthetics are used on the mucous membranes or skin is called as surface anesthesia. In surface anesthetics, the commonly used surface anesthetic agents, the most commonly is Lignocaine. Apart from Lignocaine, you can use all agents. 3 agents should be avoided, or 3 agents should never be used as surface anesthetics. What are the 3 agents which are never used as surface anesthetics? These are PMB agents. P stands for Procaine M stands for Bupivacaine and B stands for Bupivacaine. Procaine, Bupivacaine and Bupivacaine should never be used as surface anesthetic agents. Why, sir? Why? Because if you use these three agents, they can easily get absorbed from the skin, leading to respective toxicities. Hence, we don't use Procaine, Bupivacaine or Bupivacaine as surface anesthetic agents. That is an important thing that we need to remember in surface anesthetic agents. Then there is ocular anesthesia. Ocular surgeries or ocular anesthesia. First of all, you need to know for what surgeries of the eye you have to give anesthesia. Normally for cataract surgery, we give anesthesia to the eye. How will you give anesthesia to eye in cataract surgery? You can give anesthesia to the eye in the cataract surgery with the help of three routes of anesthesia. One is called as peribulbar route, other is called as retrobulbar route, and the last is called as topical route. One is peribulbar, other is retrobulbar, last one is called as what, guys? Topical route. Topical, right? So peribulbar route. If you go for peribulbar means you are going above the bulb of the eye, retrobulbar behind, okay? So if you are going for ocular anesthesia by peribulbar or retrobulbar route, the commonly used or the best ocular local anesthetic is Bupivacaine. The best ocular local anesthetic is what, guys? Bupivacaine. It's written over here. Bupivacaine is the best ocular local anesthetic. Bupivacaine is the best ocular local anesthetic. But what we use a combination. What combination? We use a combination of Lignocaine with Bupivacaine. Lignocaine with Bupivacaine, right? If at all your patient is telling, no doctor, I don't want any injection peribulbar or retrobulbar, you just topically give anesthesia to the eye so that I don't feel the pain. You can go for topical also. The best topical ocular local anesthetic is Tetracaine. Tetracaine. Tetracaine is the best topical ocular local anesthetic. Topical ocular local anesthetic. T for topical, T for Tetracaine. Remember, anesthesia to the eye can be given by retrobulbar, peribulbar or topical. Topical mein if you are giving the best ocular local anesthetic is what, guys? It is Tetracaine. Topical mein. Next, coming to this cream which is called as EMLA cream. The full form of EMLA is equal mixture of two local anesthetic. Equal mixture of local anesthetic is called as EMLA. Equal mixture of two local anesthetic is called as EMLA. Now guys, look over here. Imagine there is a child who is brought to the casualty with the complaint of UTI, urinary tract infection. For urinary tract infection, normally what we do, we give the child oral antibiotics and we tell the parents of the child that he has to be hydrated well, right? So you have advised him to give good water. You have advised the parents to give antibiotics, oral antibiotics. But what happens is, after 1 week, the same child is again brought to the casualty complaining of same burning micturition. Yani now his urinary tract infection has escalated. Now what we need to do? Now you will decide that we won't be giving him oral antibiotics. We will be giving him some IV antibiotics. But he is like a 6-year-old child and he's having needle phobia, right? He's not allowing you to put an IV cannula. To give IV antibiotics, you have to put an IV cannula. But this child, by just looking at cannula, he's dancing. He's not coming near to you, saying that, doctor, no, I don't want cannula, right? Remember guys, in our country, what we do is, if any child is there who's being not cooperating and who is not allowing you to put an IV cannula, in our country, what we do is, we hold the child's hand or we allow the attenders of the relatives of the child to come and hold the child's hand so that we can put the cannula by force. But in United States and other countries, it's not done, right? Basically, the reason being, here we are having many patients. We can't waste time on applying the EMLA cream and all. But imagine guys, this happens in United States. A child is brought to the casualty and he's not allowing you put an IV cannula. How will you put? You go for a topical anesthetic solution called, or cream called as EMLA cream. EMLA, what is EMLA? Equal mixture of two local anesthetic. What two local anesthetics are there in EMLA? Lignocaine 2.5% and Prilocaine 2.5%. You take this cream, you apply this cream on the patient's hand, and then you wait for 1.5 to 2 hours. How many hours? You wait for 1.5 to 2 hours. Why? Why? Because the onset of EMLA, it takes 1.5 to 2 hours. You wait for 1.5 to 2 hours. Then again you call the child. Now you pinch the skin of the child. Child will be telling what? No doctor, I don't have any pain. I don't have any pain. Now if he's not having pain, he will easily allow you to put an IV cannula. But the time you are wasting for it is 2 hours. In India, we are having a large OP, guys, large outpatient. We can't waste 2 hours on one patient. So what we do? 5 minutes you can put the cannula. We'll just hold the child. Child will be screaming, crying and all, and we'll put the cannula. Okay? But again, guys, we have to be sensitive about those things and all. So anyways, remember EMLA. We are talking about what? EMLA. EMLA is what, guys? EMLA is equal mixture of two local anesthetics. EMLA means what, guys? Equal mixture of two local anesthetic is called as EMLA, right? What is the composition of EMLA, guys? What is the composition of EMLA? Composition is what, guys? What is the composition of EMLA? 2.5% Prilocaine and 2.5% Lignocaine. 2.5% Prilocaine and 2.5% Lignocaine. That is the composition of EMLA. What is the indication of EMLA, guys? For which patient you have to go for EMLA? What is the indication? In children who have needle phobia. EMLA is indicated in children who have needle phobia. In children who have needle phobia. That is the indication of EMLA. That's a indication of EMLA, right? What is the onset, guys? How much time will it take for EMLA action to occur? It is 1.5 to 2 hours. 1.5 to 2 hours. That is the onset for EMLA cream. This onset is also a disadvantage of EMLA. That is a disadvantage of using EMLA. You have to, waiting time is 1.5 to 2 hours. Last is the contraindication of EMLA. EMLA should be contraindicated in which patient? EMLA is usually contraindicated in neonates. EMLA is contraindicated in neonates. Why is EMLA contraindicated in neonates? First of all, neonate, for putting an IV cannula to a neonate, you don't want EMLA. Why? Because they are neonates. They are not that, they won't create a nuisance to put an IV cannula. They'll be having pain. They'll also feel the pain, but they won't create a nuisance. But a child, he will create a nuisance to put an IV cannula and all. Neonate, EMLA is contraindicated. The reason is what, guys? The composition of EMLA is Lignocaine and Prilocaine. If you apply EMLA cream on the neonatal skin can absorb the things. It will easily absorb the things. If Lignocaine gets absorbed, there is no problem. But if the Prilocaine gets absorbed, then the neonate will land up into the complication called as methemoglobinemia. Methemoglobinemia, right? So EMLA is contraindicated in neonates. Why it is contraindicated in neonates? Due to the risk of methemoglobinemia, right? So EMLA is contraindicated in neonates due to the risk of methemoglobinemia. The risk of methemoglobinemia is highest seen with Prilocaine. If Prilocaine is not there in the option, methemoglobinemia can also be caused by benzocaine. But it doesn't mean that benzocaine is used in EMLA. Okay? Methemoglobinemia is caused by prilocaine, but if prilocaine is not there in the option, the second most common local anesthetic which can cause methemoglobinemia is benzocaine. It is benzocaine. That is regarding what? EMLA, equal mixture of local anesthetic. It is usually indicated for children who are having needle phobia. Next, coming to what? IVRA. IVRA. Come on guys, I have given you a brief introduction of IVRA while we were discussing Lignocaine. You remember the 95-year-old guy who came with the complaint of Colles fracture, right? Who was a smoker and whose heart function was heart was not functioning properly. For that, you can't give any anesthesia. You will go for IVRA, right? Yeah, you remember now, IVRA is intravenous regional anesthesia. You give the drug IV, it will cause regional anesthesia, IVRA, intravenous regional anesthesia. This IVRA was introduced by a guy called as August Baer. Now guys, once again, August Baer also we have discussed somewhere. August Baer is the father of spinal anesthesia. Remember, August Baer is the father of spinal anesthesia, and he's the same guy who introduced this technique called as IVRA, right? So IVRA is also called as it was introduced by August Baer, it is also called as Baer's block. IVRA is also called as what block, guys? Baer's block, right? August Baer has given the first spinal anesthesia in humans. August Baer has given the first spinal anesthesia in humans, and August Baer has given the first IVRA. Hence, this IVRA is also called as what block? Baer's block. Baer's block. IVRA is done under a tonic way. It is done under a tonic way. First thing in IVRA, what we need to remember is, what is the indication of IVRA? What is the indication of IVRA? For what surgeries you go for IVRA? Always remember guys, IVRA is done for the surgeries where you can apply tourniquet and block that part. Commonly for the limbs, right? Commonly for the limbs, yani upper limb or lower limb. Can you use IVRA for abdominal surgeries? Absolutely no, sir. Why? Where will you apply the tourniquet? No. So just look over here guys. What's the indication of IVRA? The indication of IVRA is what? It is usually used for, limb surgeries. Limb surgeries. Whether it is upper limb or lower limb. But surgery should be done within 1 hour. The surgery should be done within 1 hour. Why, sir? Why? Because remember guys, in IVRA we are applying a tourniquet. You are applying something with high pressure over here. The patient can withstand the tourniquet pain, or the patient can withstand the blockage of the blood supply up till 1 hour. After 1 hour also, if you are still applying the tourniquet, what will happen? Ischemia, necrosis, your gangrene can also happen, right? So IVRA is used for the limb surgeries, and this limb surgery should be done within how many hours duration? Within 1 hour duration. Then you go for IVRA. Next, what we need to remember in IVRA is the technique of IVRA or the steps of IVRA. Come on guys, what is the technique of IVRA? What's the technique guys? Come on, remember the 95-year-old guy, what I told you? I'll call my surgeon friend, I'll take the patient in the operation theatre, and first what will I do? I raise the hand for, I raise the limb. It could be upper limb or lower limb, right? Here in this case there is upper limb, but you need to remember first part in the technique is raise the limb for 8 to 10 minutes. Why are you raising the limb for 8 to 10 minutes? Why? Because to empty the hand. To empty the hand. After raising the limb for 8 to 10 minutes, next is the most important step in IVRA. The second step of IVRA is what, guys? You apply a tourniquet. You apply a tourniquet. Come on, guys. I told you what is tourniquet. What is tourniquet? Anything that is used to apply pressure is called as tourniquet. Anything that you apply on the patient's hand or the patient's legs in order to put pressure, in order to block the supply of the blood is called as tourniquet, right? It could be BP cuff, it could be a rope, it could be a glove, okay? It could be anything. So apply a tourniquet. What is the pressure? This is very important, guys. What is the pressure? Guys, whenever I am writing this QQ, it was asked as a small q over here. It was asked as a previous year's MCQ. Okay? So anyways, you apply a tourniquet. While applying tourniquet, what should be the pressure? The pressure should be what, guys? In upper limb, the pressure is different, whereas in lower limb, the pressure is different. In upper limb, what's the pressure of tourniquet? In upper limb, the pressure of the tourniquet is 50 plus systolic BP. 50 plus systolic BP. Whereas in lower limb, what's the pressure of tourniquet? In lower limb, the pressure of the tourniquet is 100 plus systolic BP. 100 plus systolic. Why so, sir? Upper limb low pressure, lower limb high pressure. Why? Why? Because in lower limb the muscle mass, fat mass is high. You require much pressure to block the blood supply. So in lower limb the pressure is 100 plus systolic, whereas for the upper limb the pressure is 50 plus systolic. This is very, very important, guys. After applying this tourniquet, the third step is you give the local anesthetic by IV route. You give the local anesthetic by what route? IV route. What is the local anesthetic which is commonly used over here? Most commonly used local anesthetic in IVRA is what? Lignocaine. Lignocaine. Come on, guys. What is the concentration of lignocaine used in IVRA? Don't turn your pages. Don't go to the slide. Try to remember concentration of lignocaine in IVRA. Concentrations of lignocaine in various anesthesia technique. The mnemonic was INI-CET. I was IVRA. The concentration is 0.5%. N is nerve blocks. E is epidural. Concentration in nerve blocks and epidural is 1 to 2%. T is topical, 2 to 4%. S is spinal, 5% of lignocaine is used. So in IVRA, what's the concentration? 0.5%. So in IVRA, you can use lignocaine, you can use prilocaine, but can you use bupivacaine in IVRA? Yes or no? You can use lignocaine, you can use prilocaine. Can you use bupivacaine? Bupivacaine should never be used in IVRA. Why, sir? Bupivacaine is not used in IVRA. Why? Because bupivacaine is the most cardiotoxic local anesthetic and it causes cardiotoxicity when you give this drug through the IV route. When you give this drug to the IV route. So it should never be given. Bupivacaine is contraindicated in IVRA. You can give lignocaine, you can give prilocaine, but you can't give what? You can't give bupivacaine. You can give lignocaine and prilocaine, but you cannot give bupivacaine. The moment bupivacaine enters the systemic circulation, patient will develop what? Patient will develop cardiotoxic effects of it. And you know, bupivacaine-induced cardiotoxicity is very, very, very difficult to manage. Even though the drug of choice or an antidote against bupivacaine we are having, what is the drug? It is intralipid solution. How much percentage? That is also important. How much percentage, guys? 20% intralipid solution is used. So guys, coming to the next thing, tell me IVRA is contraindicated in which patients? In which patients should you never give IVRA? Which patients, guys? Imagine a patient is suffering with Raynaud disease and he is having Colles fracture. Raynaud disease and Colles fracture. Will you go for IVRA? Never, sir. Why never, sir? Why? Because remember, Raynaud disease is what? is a vasospastic disorder of the upper limb, basically of the fingers. In Raynaud's, the blood supply to the finger is already hampered. If you go for IVRA, you will apply a tourniquet which will further hamper or which will further worsen the disease, right? So remember guys, IVRA is contraindicated in the conditions where putting tourniquet is contraindicated. What are the conditions where putting tourniquet is contraindicated? One condition is Raynaud's disease. In Raynaud's disease, you never go for IVRA. Yani Raynaud's disease patient having Colles fracture, you never go for IVRA. Apart from that, what else? IVRA is also contraindicated in patients who are suffering with sickle cell anemia. Why sir? Why sickle cell anemia IVRA is contraindicated? Why? Because a person who is suffering with sickle cell anemia, if you apply tourniquet, leave IVRA, in a sickle cell anemic patient, if you apply tourniquet, what will happen? Always remember guys, sickle cell patients, you have to avoid the things that causes hypoxia, because hypoxia can make the things worse in sickle cell anemia. Patient might develop vaso-occlusive crisis due to hypoxia. If you go for IVRA in sickle cell anemia patient, or if you apply tourniquet, what will happen? This tourniquet will block the blood supply, leading to hypoxia of this part of the limb. That can cause what? Vaso-occlusive crisis. So remember guys, IVRA is contraindicated in Raynaud's disease. IVRA is also contraindicated in sickle cell anemia. Sickle cell anemia. If you go for IVRA in sickle cell anemia, what will happen? It can lead to vaso-occlusive crisis. It can lead to what crisis? Vaso-occlusive crisis. So guys, this was regarding the local anesthetics, and this was regarding the techniques which we have discussed in local anesthetics. Some techniques like IVRA we have discussed. We have discussed the topical, and we have discussed most of the things. Okay, so guys, this was the topic regarding local anesthetics. Okay, thank you guys.